Thank you for viewing this educational program. This module discusses urethral stricture disease. To better understand urethral strictures, let's first discuss some basic male anatomy. The male urethra is a long tube that extends from the bottom of the bladder or bladder neck to the tip of the penis or urinary meatus. For classification, it is divided into the anterior urethra and posterior urethra by the urogenital or pelvic diaphragm, which makes up the muscle of urinary control. The anterior urethra involves that part of the urethra within the penis and also the bulbar urethra, which makes the curve from the penis towards the bladder under the pubic bone. The bulbar urethra ends at the level of the so-called urogenital diaphragm. Once the urethra enters the urogenital diaphragm, it becomes the posterior urethra, which is further divided into the membranous urethra and the prostatic urethra, as shown here. The prostatic urethra is that part of the urine channel that courses through the prostate before connecting into the bladder. These divisions of the urethra are important because different conditions affect different parts, and treatment options vary based on the location of the problem. So, what is a urethral stricture? Essentially, a stricture is a narrowing of any hollow tube in the body that interferes with the passage of fluids or solids through that tube. The narrowing is usually caused by scar tissue formation, which develops following an injury or some type of inflammatory process. Two common examples in the body are strictures of the esophagus or food pipe and the urethra. If a stricture forms in the esophagus, a person would have difficulty moving food into the stomach, while in the urethra, a stricture will limit the passage of urine out of the body. Many men are surprised to find that they have developed a stricture, as they cannot pinpoint a time when an injury had occurred there. In presenting to their doctor, a patient may notice that it takes much longer to empty his bladder and that he must now push with his abdominal muscles to help emptying. Some men develop a split or forked stream. This can reach a point where they will sit to void, as hitting the toilet from a standing position becomes impossible. On occasion, it may burn within the urethra while urinating, and blood may even be seen mixed with the urine. Typically, a man may find that some urine dribbles out onto the underwear after he has finished urinating and walked away from the toilet. Because of poor bladder emptying and abnormal flow, men with stricture disease may develop infections in the urinary tract. Finally, if left long enough, the scar tissue may completely obstruct the urethra to the point that urine becomes trapped in the bladder. This is known as urinary retention and requires emergency treatment. Injuries to the anterior urethra, or that part of the urethra within the penis, often result in the development of a stricture. These injuries are often referred to as straddle injuries and include falling onto a metal bar such as a bicycle frame, fence post, or jungle gym. Other injuries may have been more obvious, such as a knife or gunshot wound to the genital area. Rigorous sexual activity or sexually transmitted diseases like chlamydia or gonorrhea can also result in injury to the urethra. Finally, in the modern era, a common cause of urethral injury occurs during instrumentation, such as by a catheter at the time of surgery or during cystoscopy. Regardless of the cause, the injury to the lining of the urethra can result in healing with scar tissue, creating a stricture that narrows the passage. Injuries to the posterior urethra typically occur in association with major life-threatening injuries during a motor vehicle or workplace accident. The urethra may have been completely disrupted or torn from its normal attachments, resulting in loss of continuity with the bladder. Violent trauma to the pelvis from gunshot or stab wounds can also disrupt the posterior urethra. The final cause of injury to this part of the urethra is interventional procedures. This is known as iatrogenic injury. For example, during healing after prostate surgery, radiation, or other prostate treatments, scar tissue at the bladder neck may obstruct the flow of urine from the bladder to the urethra. After taking a patient's history, a urologist may suspect that a man has a stricture. Physical examination of the genitals often does not reveal the scar tissue from outside the body. However, an overdistended bladder may be felt. By having a patient urinate into a special machine and then assessing the volume of urine remaining in the patient's bladder, a urologist can assess a patient's urine flow and emptying ability. This is called a uroflow and bladder scan. The urologist can also perform an internal inspection of the urethra and bladder, called cystoscopy, by advancing a long, flexible tube under local anesthetic or freezing down into the urethra and bladder. This will usually identify any significant strictures. This image shows a typical cystoscope used to look into the urethra and bladder. Finally, the urologist may have an X-ray of the urethra done by injecting a solution of X-ray dye down the urethra towards the bladder. This gives a black and white picture of the full extent of any scarring, and is called a Retrograde Urethrogram. In this X-ray, the contrast or X-ray dye comes to a blockage at the location shown by the circle. This is the site of a short bulbar urethral stricture. To improve urination, the scar tissue must be stretched, cut, or removed. Stretching of strictures has been done for centuries, and medical history books show instruments that have been used to do this. In the current day, some of these same instruments exist. However, modern anesthesia and antibiotics have improved patient care. Urethral dilation involves stretching the scar tissue open in a sequential fashion, usually under local anesthesia or freezing. Because the urethra may be very narrow, a small dilator or urethral sound is used first, followed by larger and larger dilators to open up the narrowing. Once open, the urologist may choose to leave a catheter in for a few days to help the urethra heal. Once the urethral stricture is open, the urologist may teach the patient to insert a small catheter once or twice a day initially to maintain the opening. This is referred to as self-dilation. If dilation of the stricture is not enough and the stricture returns, the urologist may cut the stricture open using a metal knife and telescope with the patient under general or spinal anesthesia. This is called a visual internal urethrotomy, or VIU. Again, a urethral catheter is left in place for several days afterwards to assist in healing. Dilation and urethrotomy are two techniques that make up the standard therapy for strictures by many urologists. Unfortunately, stretching or cutting scar tissue often results in healing with more scar tissue. Therefore, the stricture returns. Many patients will report that they feel great initially, but unfortunately, it lasts for only 3 to 6 months, at which point they require a repeat procedure. Depending on the length of the stricture, recurrence rates are between 40 to 80% by 1 year. With each stretch or cut, the urethra must be instrumented, so infection and injury of other areas causing a new stricture is always possible. For this reason, antibiotics are typically required around the time of the procedure, and most patients will go home with a urethral catheter for a couple or few days. The catheter allows healing of the urethra and prevents bleeding by compressing the wall of the urethra at the site of the surgery. Many urological surgeons do not do urethral reconstructive surgery, so they may refer you to a urologist who has received extra training in this area. Because the urethra is a hollow tube, repairing blockages depends on the length and location of that blockage. If it is a short stricture, your surgeon will consider a primary repair, in which the stricture is cut out of the urethra and the two good ends are sewn back together in a tension-free, watertight fashion. This image here shows a primary repair, with the cut ends of the urethra being sewn back together over a catheter. If the stricture is too long for this type of repair, your surgeon may need to substitute part of the urethra's wall with another material from your body. This operation is called a substitution urethroplasty. A graft is a surgical term to describe a piece of replacement material from your body which is transferred from one location to another without bringing along that material's blood supply. Once a graft is put into the new location, the body will grow a new blood supply into that tissue. For urethral reconstruction, typical graft materials include tissue from the lining of the cheek or skin from another part of the body. A flap is another surgical term to describe a piece of replacement material from your body, which is transferred from one location to another, but brings with it its own blood supply, therefore not relying on a new blood supply to develop. Surgeons will often argue the merits of flaps and grafts because they are always looking for better ways of repairing problems. This image here shows a graft of tissue being used to repair the urethra during urethroplasty. This drawing shows a flap of nearby skin being moved into place to help reconstruct the urethra during urethroplasty. Note that the flap's normal blood supply is preserved and comes with it. Your surgeon may also discuss the need to stage your stricture repair. Most surgeons prefer a single stage repair in which the stricture is repaired in one single operation. However, sometimes a staged operation is needed. In a two-stage procedure, your surgeon will open the stricture up to the skin because of infection or because he or she feels that a single stage operation will not work. If this occurs for 3 to 6 months, your opening for urination may be under your scrotum or in the shaft of your penis as shown in these figures. Once the area heals, your surgeon will do a second operation to repair the urethra. Many of these decisions are made in the operating room based on an individual patient's problem. While this discussion may sound confusing, this information is provided to give you some insight into some of the complexities of urethral reconstruction and why your surgeon may suggest different options. Success rates for open urethral reconstruction are between 70 to 90%, depending on the difficulty of the stricture. All surgery has potential complications. Infection and bleeding are possible complications of any surgery because your surgeon must break the protective skin barrier to access the affected parts of your body. This is no exception with urethral surgery. If the stricture is within the bulbar urethra, your surgeon will make the incision under the scrotum with your legs positioned on stirrups suspended above your body. If the stricture is within the penis, your surgeon will make the incision on the penis lengthwise or like a circumcision. Despite careful planning and surgery, urethral surgery heals with some scar tissue, and the graft or flap of new tissue needs to heal into position. If any problems in healing occur, a stricture may reoccur. After surgery, you may find that your stream is not perfectly straight. This is due to healing within the urethra that may not be perfectly smooth. Like a pebble in a stream, turbulence develops and the stream may split. In almost all cases, the erections should not change after urethral surgery. However, your surgeon cannot guarantee this. Because your surgeon may need to use a piece of skin from inside of your mouth or from your penis or scrotum, certain changes may occur at that site. In the mouth, the salivary duct may be injured. The nerves in the mouth may be injured, resulting in numbness on the cheek, and you may feel scar tissue inside your mouth. Your surgeon may insert a tube directly into the bladder from the lower abdomen to drain your urine, which is called a suprapubic catheter. Inserting this tube can cause injury to bowel, bladder, and blood vessels. Finally, when your surgeon operates under your scrotum, he will need to position your legs high in the air. Injuries to the nerves of the legs and arms, as well as blood clots to the legs and lungs, may occur, despite your surgeon's best attempts at protection. These complications do not happen often. However, it is important to be aware of the things that can happen before consenting to surgery. Typically, urethral reconstructions require 2 to 4 hours of operating time depending on the length of the stricture and the complexity of the surgery. Most patients will wake from surgery with a tube or catheter in the penis, a drain near the incision, and possibly a suprapubic tube as described previously. The drain will be removed during your 3 to 5 day hospital stay. However, you will be discharged home with the urethral catheter in the penis and the suprapubic catheter if you have one. Most surgeons keep these tubes in place for 2 to 3 weeks, during which time you cannot work. Home care nurses are often arranged to help you with wound care and tube care. If you are having difficulty, your nurse, surgeon, or local emergency room can assist with problems. To summarize, urethral strictures occur when scarring of the urethra causes narrowing, thus making it difficult to urinate. There are several ways in which the urethra or urine tube may have been damaged. Once diagnosed, there are several management strategies, each of which comes with risks and rewards. Unfortunately, urethral strictures have a tendency to recur after surgery, but many patients can expect successful treatment. Thank you again for viewing this presentation.